Good afternoon, everybody. Today we'll be talking about a new topic, and that is abdominal wall surgical anatomy as related to abdominal wall hernia. As you all know, abdominal wall is a very important part when we talk about any kind of hernia in the abdominal wall, whether it's the ventral hernia, groin hernia. And until we understand the anatomy of the muscles which are in the abdominal wall, especially the obliques, the transverses, and the rectus abdominis, it becomes slightly difficult to understand how the hernias appear, and then more important, how we try to uh, relieve the patient of these hernias, right? Now, basically, just to start, I'd like to put in some disclosures because with the COVID lockdown, I've not been able to take the proper copyright permissions. We've used a number of figures and number of um, photographs from the internet and from the book Master of Surgery Fishers and Surgery of North America. But then this is basically for this lecture only, a non-profit kind of use for this. Now let's start with musculature of the abdominal wall, and if you, as you can well see that the important musculatures could be seen in this figure, and the important part which is lying underneath, below the costal margin and the sternum would be the four important muscles: first external oblique, the internal oblique, the trans abdominis, the rectus abdominis, which is rectus sheath, and these are basically the muscles which make up the wall of the abdomen and important, all important muscles for ventral hernias and ischial hernias and groin hernias. Talk about the first muscle, and there's the external obliquus. And if you look at the external obliquus, it basically is a muscle which is arising from above and going down. So it's arising from the outer surface and lower margin of the lower eight ribs and the interdigitations of the cercus anterior and the latissimus dorsi, right? So the latissimus dorsi. So basically in the rib, they are the origin external oblique, it interdigitates with the origin of these muscles. Okay. Now it is inserted right from the feet down because going downwards and medially. So starting from the sternum, the whole of the linea alba, and then the forms the inguinal ligament in between the antispheric spine and the pubic pubic symphysis, and over the crest of the abdomen, the crest of the iliacus bone, and the pubic tubercle here. So in between these two, as I said earlier, it forms the inguinal ligament. The function is basically, as you can well judge logically, it's the flexion of the spine, increase the internal pressure in valsalva maneuvers by contracting, and same side dorsiflexion. But what is peculiar is it's basically a contralateral rotator of the torso. The blood supply is coming from the cranial portion of the muscle by the lower intercostal arteries, the caudal portion by the branch by the deep circumflex artery or the ilio-lumbar artery, as we'll be seeing in the future slides. And the nerve supply is the ventral branch of the lower six thoracoabdominal nerves and the subcostal nerve on each side. Looking at the second muscle, the internal oblique, running at exactly right angles to the fibers of the external oblique. So this is basically arising from the lower part and going up. So it is arising from the anterior two-third portion of the iliac crest, the lateral half of the inguinal ligament, and the thoracodorsal fascia out here. The thoracolumbar fascia, thoracodorsal fascia, right? And these fibers are now going up exactly at right angles to the external oblique fibers. And they would be then inserted right from the inferior border of the 10 to 12 rib. You can see these 10 to 12 rib and the linea alba, the midline, and the pubic crest via the conjoint tendon, right? So it forms arching fibers out here and then attaches itself to the pubic crest, right? The muscle fiber, the internal oblique, they course upwards, as I said earlier, perpendicular to the external oblique. The supply of the nerve is the same from T6 to T12 nerves, and the blood supply is again from the same source, the lower posterior intercostal subcostal arteries, the superior and inferior epigastric arteries, the superficial and deep circumflex iliac arteries, and the nerve supplies from the terminal branches of T7 to T12. The iliohypogastric and ilioinguinal nerves, they contribute to the nerve supply of these muscles. These are nerves, as we all know, they're arising from the lumbar plexus, and the functions are again opposite to the external oblique, which was a contralateral rotator. This is basically the same side rotator of the torso in contradiction to the external oblique. And basically, it's important is it's an opposer of the diaphragm. That basically means it is having absolutely opposite action diaphragm and that's why it helps in post-exhalation. The other actions are similar, flexion of the spine and same side bending, as was there for external oblique, for the external oblique muscle. Coming to the third muscle, and that's the transverse abdominis, thin sheet of muscle whose fibers are now running horizontally. So you had one coming down and medially, the other going up and medially, and now we go to transverse fiber, right? So is basically arising the deep surface of the lower six costal cartilages out here, the lumbar fascia out here, the anterior two-thirds of the iliac crest out here, and the lateral third of the inguinal ligament out here. So this is basically the fibers are lying just behind the internal oblique, along the iliac crest, the spheric spine, and the inguinal ligament, right? Now, anteriorly, it is inserted in a broad aponeurosis, the spigelian fascia, below the umbilical line. You can see this becomes aponeurotic out here. The aponeurosis has got the widest, it becomes widest in and around the umbilical, right? So that's basically the spigelian fascia, more pronounced below the umbilical line. It is lying even up, but it's more pronounced out here. The lower fibers, they curve along with the fibers of internal oblique inferior-medially, and inserted together with those internal oblique muscles into the crest of the pubis bone and the pectineal line, forming the inguinal conjoint tendon and also rather known as the aponeurotic part. Now, throughout the rest of the extent, the aponeurosis passes horizontally to the midline, and there it basically joins the posterior division of the internal oblique aponeurosis, right? Now, basically slightly different above and below, and we're showing that when you talk about the rectus abdominis muscle. Now, the lower fiber, for the rest of the extent, it is basically aponeurosis passes horizontal to the middle line, as said earlier, and below the arcuate line and above the arcuate line is slightly different, because below the arcuate line, it goes anterior, forming totally the anterior sheath, and above the arcuate line, it takes part in forming the posterior sheath of the rectus abdominis muscle, right? Now, the blood supply, again, the same vessels, the posterior intercostal and subcostal arteries, superior and inferior epigastric arteries, the superficial and deep circumflex iliac, and the posterior lumbar arteries, right? The function is the same to a certain extent. Basically, it would again be flexor, but then it is very important as a muscle providing pelvic stability, along with the other muscles, the posterior muscles, including the multicipitator muscle, one of the transversus spinalis muscles, and it is providing both the thoracic stability also. Now, it helps to compress the ribs and the viscera, right? Now, basically, if you look at the anatomy in one figure, you see these fibers, and what is to be noticed out here is that this is basically a linea semilaris running out here, and see how wide it is in the region umbilicus. See how wide it is, right? And here muscles have been cut. So you got the external oblique cut out here, then you got the internal oblique out here. And you see the vessels out here. Now, vessels basically, peculiarly, they run between the transverse abdominis muscle and the internal oblique muscle. Saying what? It gives you a wide hint as to the fact that you can easily go and dissect in between the external oblique and the internal oblique, as we see in any patient who's had or who's being subjected to anterior component separation technique. Now, when you look at the anterior component separation, it is basically separating what? It is separating the external oblique and the internal oblique, and then cutting the aponeurosis of the external oblique. Now, if you have to dissect in between, and there were blood vessels lying out here, then it would have been a problem. So there are no blood vessels there. These blood vessels which enter the external oblique, they stop at the anterior line, and the vessels are primarily now lying in between. You see, this is the internal oblique. See the internal oblique, and then underneath you got the transverse abdominis. So these vessels are lying in between the internal oblique and transverse muscle. So you cannot dissect in between the transverse abdominis and the internal oblique, right? You cannot. If you do, then of course you are leading to a lot of ischemic damage by damaging the blood vessels. But you can easily dissect right from the top or the subcostal right to the pubic bone. You can dissect easily and separate both the external oblique and the internal oblique aponeurosis right up to the midline, and of course laterally we can go right up to the mid-axillary line. Okay, now that plane can easily be created. So that is basically the use of this, understanding this anatomy when you try to use this knowledge when you want to do an anti-component separation technique. So this is how it looks like, right? So this figure is very important. Here you can easily see the vessels running out. So if you look at the applied anatomy, just now told you, the plane between the external oblique and internal oblique is completely avascular and can be dissected with great ease, right? I just now told you that. And because running in between internal oblique and transabdominis, you cannot do that, right? When you do a Carnes test, which is basically the straight leg raising test, when you are basically extending your knee, and if you lift the extended knee unsupported, then you know the end muscles, they contract. That basically one of the tests by which you differentiate between abdominal and parietal swelling. Now, this basically test takes the fact that you have got a fascia, that's the deep fascia of the thigh. Laterally, it is condensed to form the tensor fasciae lata, and this basically is attached where? Attached below the knee, right, onto the tibial condyle. Now, when the extended leg is there, it is basically tensing the tensor fasciae lata. And when you're tensing the tensor fasciae lata, you're going to pull the whole of the inguinal ligament down, right? So in the extended knee, the whole of the inguinal ligament is going to be pulled down. When it pulls it down, it's going to pull the external oblique down. So that is why the muscles tense. So that's the basis of the Carnes test. So extended knee is very important, right? Otherwise, if you had a flexed knee, the abdominal muscles would what? They would relax. The abdomen would become softer in a relaxed position. But when you do the same test in extended knee, the whole thing is dragging onto the inguinal ligament, the tensor fasciae lata, the deep fascia of the thigh. It's dragging. Why? Because it's attached to the undersurface of the inguinal ligament. That's the attachment of the deep fascia of the thigh and the tensor fasciae lata. So when you're extending the knee, you're pulling everything down, and that is why the external oblique tenses and the abdominal wall becomes tense, right? So that is basically the basis of a Carnes test, the anatomical basis of Carnes test, right? The rectus abdominis muscle, we all know it arises from the pubic symphysis. Again, a muscle rising below and going up. So from the pubic symphysis, the pubic crest, and the pubic tubercle inferiorly, and upper, the insertion is to the xiphoid in the midline, and the costal cartilages of rib number 5, number 7 superiorly. Now, there are tendinous intersections which further subdivide each rectus abdominis muscle into 6 to 8 smaller false muscle bellies, 3 on each side, 3 or 4 on each side. That basically makes it 6 to 8. Now, it is separated from the fellow's opposite side by the centrally running linea alba. Now, whenever you got a diastasis linea alba of gap of more than 2.7 centimeters between the two sides, then you call it what is known as the divarication of the recti or diastasis of the recti. Now, the intersections that you find, they're important in one respect, that these intersections, they convert the muscles into small segments. Now, if you had a single muscle, if there were no intersections, it was a muscle running right from the xiphisternum down here. And if it contracted, it would have given a bowstring effect. You contract a large muscle, it bows. It's got one attachment here, one attachment here. So it will bow like this. So if it bows, the action becomes inconsequential. Why? Because the plane of action will no longer be there in a straight line. But suppose if this muscle is hinged at places, when it contracts, it's going to contract like this. That means the vertical effect would always be there. When it has got a bowing effect, the vertical effect is minimal. And that is exactly the reason why you have these tendinous intersections. It is converting one single long muscle into 1, 2, 3, 4 smaller muscles. And each of them is going to contract where? Point number 1, point number 2, point number 1, point number 2, point number 1, point number 2. That means it's going to contract only in this small space. This small space. So that means each muscle is contracting individually, so you don't have the bowstring effect at all, right? That is why it gives a graded increasing flexion of the torso. If it had been a single muscle, the bowstring effect would not have resulted in an increasing flexion, right? Now, these three intersections, one is at the xiphoid, the second at the umbilicus, and the third is midway in between. So you got one at the umbilicus, one at the xiphisternum, and somewhere in between you may have an additional one out here. So there are either 6 or 8 bellies, and they would contract individually and progressively. So basically the function of rectus abdominis would be tensing the abdominal wall, flexing the trunk, stabilizing the pelvis, and aiding in childbirth, defecation, micturition, and any kind of forceful action, including forced expiration. So that is basically the egg rectus abdominis. Have the intersection. The blood supply is again very, very important, and the place where you find the blood supply is also very important, right? The inferior epigastric artery and the superior epigastric artery are basically there, and they lie posterior to the rectus abdominis muscle. So that means the vessels are lying in between the posterior part of the rectus abdominis muscle and the anterior part of the sheath. Okay, so that means the posterior rectus sheath and anterior to that and posterior to the rectus abdominis. So this vessel is lying there, and that is important. Now the inferior epigastric, the deep part or the deep inferior epigastric, or known as the inferior epigastric artery and vein, they enter the sheath just at the arcuate. Below the arcuate, they are lying where? Inside the preperitoneal area, and where? In between layer number 1 and layer number 2 of the transalus fascia. I hope you all remember what the transalus fascia is all about. Got 3 layers to it: layer number 1, layer number 2, and layer number 3. So 1 and 2 is the layer where you have all the vessels, right? Similarly, the inferior epigastric artery is entering there. We'll talk about the artery in a short while. So that is number 1. Number 2, you have got the veins along with that. That means the epigastric vein and the superficial epigastric vein and the superior epigastric, right? So superior and inferior are lying inside the sheath, and superficial epigastric vein is lying outside the sheath. I'll just show you a diagram. And then, of course, you've got the rectusal veins. Hitherto less known, but with the advent of laparoscopic surgery and the anatomy of laparoscopic surgery for inguinal hernias, now we know what rectusal veins are all about, right? The nerve supply, thoracoabdominal nerves, continuation of T7 to T11 intercostal nerves, and they pierce the anterior layer or the anterior part of the rectus sheath. That is where they enter, right? Now, this is what it's all about. This is basically the rectusal group of veins. Now, if you look at this figure, this is the rectusal vein. Now, this is the lateral edge of the rectus abdominis muscle, and this is the rectusal vein. And it has got a number of tributaries to it. Now, 1, branch number 2, and then it anastomoses with 3 important veins. Here, look, this is the inferior epigastric. There's the iliolumbar vein running along the upper border of the pubic bone. And then you've got the retropubic vein just behind the pubis and anastomosing out here. So see this arcade. This arcade is very, very important. This arcade becomes important. Why? Because this is an arcade which is lying between layer number 1 and layer number 2 transalus fascia in the lower part of the abdominal wall, to be more exact, in the inguinal region. And this arcade is known as the arcade of Bendavid. Venous circle of Bendavid, you can look it up if you want to have more information about this. This is basically the area. And if you look at this corresponding figure out here, we are talking about this particular area. This is a particular area that you'll find this arcade, right? This is the area and the arcade. And this is again important. Why? Because when you're doing a dissection posterior to the rectus abdominis in the preperitoneal area in the inguinal region, you be careful that you don't injure this arcade, because this gives rise to trouble, some bleeding, and that creates a lot of problems, right? Now, the rectus sheath, as I said earlier, if you look at the rectus sheath, multi-layered aponeurosis, which encloses 2 muscles, the rectus abdominis and the pylomadalis muscle, right? Above the arcuate line, you got the anterior and the posterior wall. The anterior, it is the aponeurosa external oblique, and the split aponeurosa internal oblique, the anterior layer. Now, if you look at this figure, is this figure clear to you? Look at this figure, and this figure, yeah. If you look at this figure, just here it is. Okay. Now look at this figure. You see this figure, the internal oblique splitting into 2, the anterior and the posterior. The anterior combines with the external oblique. This combines with the transverse abdominis. And below you got the peritoneum attached to it, right? Now at the level of the arcuate line, all the 3, the transverse abdominis and the 3, they go and combine. Below this, now they start the arcuate line, and below the arcuate line, you have this combination where the internal oblique no longer splits. Transverse abdominis goes and joins the internal oblique, and together they form the anterior, right? Together they form the anterior. So there's a difference in the upper third, at the level of the arcuate line, and at this particular area, right? Now, coming back to the vessels. Now, look at this particular area. I was telling you these vessels lie in the anterior to the posterior layer of the sheath. Now, see, this is the sheath. Can you see the sheath? and see the vessels. So above the arcuate line, you'll find the vessels situated between the muscle and the sheath. Now let's go below the arcuate line. What's happening out here? There's no posterior sheath. So here you've got what? The transhalus fascia, and you've got the posterior part of the rectus abdominis belly. So the vessels are lying out here. That's what I said. This is the area where the dissection is there when you're doing a laparoscopic. Even otherwise, you're doing an open repair, any kind of open repair in the lower part of the abdomen below the umbilicus. There you have a problem where you may land up with a problem with injuring these vessels, right? So remember this, very important. And see the side. See the side. Again, very important. It is lying at the lateralmost edge of the sheath. That's again very important. Lateralmost edge of the sheath, not medial. Why? I'll just tell you when we proceed forward, right? Now, if you look at the vectors of forces in the abdominal wall, see, the rectus abdominis only contracts and gives rise to vector force in the longitudinal plane, craniocaudal. Okay? When you look at the external oblique, it is basically applying forces which are proceeding upwards and outwards, as opposed to internal oblique proceeding downwards and outwards, right? And transverse abdominis are horizontally outward. So this is basically the horizontal force together, because together, if you look at all the forces acting together, the transverse forces are twice as much as the longitudinal. Very aptly depicted in this figure. See, the transverse almost 2 times the lateral one, and that is why we talk about ventral hernias all the time when we talk about the midline incision, we talk about the paramedian incision, and so on and so forth, right? And this basically is the force is being equally based on some law. We'll talk about this law in just a short while. The force is going to be distributed equally on all parts of the abdominal wall, except if there are additions, right? So this is an equal distribution of force. So that these vectors have to be known important. Now let's talk about the vessels. Now if you look at the vessels, these are the arteries. We just talked about the arteries. See the inferior epigastric, the superior epigastric. Okay. Now let's talk about the deep circumflex iliac, ascending branch, and lower intercostal and subcostal. Right. So the terminal branches, the thoracolumbar, and the terminal branch of internal thoracic artery are 2, the thoracolumbar, and number 2 superior epigastric. So here the anastomosis is there, right? So the ascending deep circumflex, the deep circumflex, not the superficial circumflex, okay? That is lying more superficially. And the 2 major vessels, the superior and the inferior epigastric, right? And what is important about them is, look at these perforators. These perforators are very important. And why are they important? The importance of these perforators is all the much more when you're dissecting or you're trying to lift the skin over the muscle. As you do when you're trying to do a laparotomy and you want to apply stitches and you say, let me dissect the skin of the muscle so that I can apply better sutures. Now that is one area we have to be very, very careful. Look at these perforators, right from medial down to lateral. You must have experience when you try to dissect the skin of the perforator, it leads to a lot of bleeding. It's a lot of bleeding. Why? It is these perforators, not only arterial, even the venous perforators that make that create the problem. On the other hand, if you look of the superficial, you got the superficial epigastric artery and you got the superficial circumflex artery. Now these 2 arteries are basically supplying, the pudendal supplies only a very, very small area in lower part of the abdomen, right? Lower part of the abdomen. But otherwise, you basically have to remember the 2 epigastric, the thoracolumbar, the deep circumflex iliac, and then of course superficial circumflex iliac and superficial epigastric, right? Now, so again, let's come back to this. The deep arteries between transhalus fascia number 1 and layer 2 are which? The 2, the deep inferior epigastric and the deep circumflex iliac artery. I'm not going to go into the details of that, but remember, all the deep vessels have to arise from the external iliac. The superficial have to arise from the femur, whether the artery or the vein. Okay? The deep, in the inguinal region, remember the deep vessels always arise from the external iliac, and the superficial, they always arise from the femur, right? So the anastomosis is very important. I was showing you the anastomosis. This anastomosis is very important. All the anastomosis along with that. That's why they give rise to such a good vascularity of the abdominal wall. Anastomosis here, anastomosis here, anastomosis here, anastomosis here. So all anastomosing along with that. Along with that, they give rise to perforators. All the facts are very, very important, right? Similarly, if you talk about the superficial artery, now where are they lying? They're lying in fascia scarpa, just superficial to the external oblique aponeurosis. They're not deep to it, they're lying superficial to it. And again, the three vessels that we just all showed in the last diagram. These are superficial vessels, right? Superficial epigastric, see out here. Then superficial circumflex iliac, again lying below the inguinal ligament and lying superficial to the fascia out here, and the external pudendal. So these are all lying external to the external oblique aponeurosis. The others are lying deep to it. Okay. Now, the blood vessels, the anterior wall, the superficial, we just now talked about these superficial vessels. Now, what about the neurovascular? All the neurovascular structure supplying the abdominal muscle, we just now talked about that. The lying in between the internal abdominal, internal oblique muscle and transabdominal muscle, right? We just now talked about that, where we can easily do that. The dissection when we want to do a transverse abdominis flap, right? But what about the nerve? The two important nerves which we all consider, and these are iliohypogastric and inguinal. We are not much concerned about the intercostal nerves in the abdomen because we don't carry out any dissection in that particular area, and moreover they are so well distributed they hardly have any area of hypostasia. But when you talk about these two nerves arising from the lumbar plexus, the iliohypogastric nerve and the ilioinguinal nerve. When you talk about these two nerves, now these two nerves arising from the lumbar plexus, initially they lie on the anterior surface of the quadratus lumborum muscle. We know that. Then they pass laterally, they have to come anteriorly. When they pass laterally, they would lie in between the transverse abdominis and the internal oblique muscle. Right? Now, once they have punctured the transverse abdominis and now lying in between transverse abdominis and then oblique. At the level of the ASIS, anterospinal spine, now they also perforate through the, or they reach from the through the internal oblique and now lie in between the external oblique and the internal oblique. So see the course that they are following. Initially over the quadratus lumborum, you have to imagine this in your mind. Initially over the quadratus lumborum, then perforating the transverse abdominis in between transverse abdominis and internal oblique. Now at the ASIS, now perforating the internal oblique. So when you do a dissection in the inguinal area, where do you find these nerves? As soon as you give an incision over the external oblique aponeurosis, lift both the edges, you find these two nerves in front of you. That basically means what? It's lying in between the external oblique and the internal oblique one, right? So that is very, very important. Right. The veins, very, very important. The veins are very, very important. Why are they important? The reason why these veins are important is that these are the veins which are responsible for a number of problems, right? What are these problems? Let's talk about the veins first of all. Number one, similar to the artery, they're following similar to the artery. So you've got the superior epigastric vein, and you've got the circumflex iliac, external pudendal, and tuberties, they are lining from the femoral, just like that, right? Let's go further. Now see this figure. Now this is the superficial inferior epigastric vein. Okay, this is the deep inferior epigastric vein, right? This lying in the rectus abdominis, below the rectus abdominis, subcutaneous plane. I told you in the above the fascia scarpa. Now there is always a perforator in between these two. They always perforator creeping from the superficial epigastric into the deep epigastric. Okay, so this is how it looks like. See the superficial epigastric vein coming out here, and these are the veins, the internal thoracic, the lumbar veins. There is a very good anastomosis out here, and this is basically, if you remember, if you talk about the portal hypertension, the anastomosis around the umbilical combination. What? See, lateral thoracic vein is combining with what? Axillary vein out here, and this is combining with what? Draining where? In the femoral. So you have above and below. This is the external iliac. Above this is the external iliac. This will go into the superior vena cava, inferior vena cava, superior vena cava. So basically, you have a alternate route of venous vein. Okay, so and what else is important is that the inferior superficial epigastric vein, they always send tributaries across the midline. Across the midline. For those who are PGs in this lecture room, you have to understand this much better. Why? Because these are the veins which are crossing the midline, and if you cut these veins or there's damage to these veins, it always leads to area of ischemia in the periumbilical area. So remember, the superficial epigastric vein always communicates with the deep with perforators. It also communicates with similar veins above the umbilicus draining into the axillary system, right? Now, this is about the superficial epigastric vein. I just talked about it, so I won't go into this detail, but just remember the plane. The plane is very important, superficial to the scarpa's fascia, superficial to it, and crossing the midline with tributaries, crossing the anterior rectus sheath with tributaries of perforators to the deep system. Similarly, the deep venous system. So I think we all talked about that. Right. So, in case if you find this lecture now, just note this down. Those who are on this lecture, the ID is 732. Just note it down. ID 732 6652 5078, and the password is 014059. So as soon as, suppose if the lecture stops, then you can go into this ID. I've already taken that 40 minutes more, so you can easily tag on to the middle. Okay, once we stop on this, until we continue with this, no problem. Okay, so we talked about the one more other thing is important, and that is the communication is there between the superficial and the deep system, just like in the leg. It's just like in the leg. In the leg, you have the saphenous system, you got the deep system. So there is always a perforator communicating between the two. Similarly, in the abdomen also, you got the superficial system and the deep system communication. And just like in the lower system where there are walls, here also there are walls which suggest a caudal venous flow in both the systems. That basically means directing flow from the superficial to the deep. Right? Just like in the lower leg, superficial to the deep. You know that saphenous goes to the deep system. Similarly, out here, what's happening? Here also, the superficial system is draining or is in communication with deep system with walls which are directing the flow to the deep system. Okay? Right. Now, what is the applied anatomy of this vasculature we talked about, the perforating we talked about? Very, very important. And that is, number one, the skin undermining in the periumbilical region should be kept to a minimum. Remember this. Keep it to a minimum. All those who are doing surgery, remember that. The undermining of the skin in the regions of umbilicus should be kept at a minimum. Why? Because there is a maximum concentration of perforators, both arterial and venous, into this particular area, and you don't want to damage them. The moment you start damaging them, that part of the skin undergoes what? Ischemia. And that is often very evident in all those residents who are in this lecture. Remember when you were doing or you had done a laparotomy and this patient had SSI, and the first part to break out was the umbilicus. Why? Because that is the area where undermining had led to a severe degree of ischemia, and that is the part which breaks open early. It breaks down the earliest. So remember, the umbilical area is very important, and that's why you have to be very careful when you undermine that particular area. The undermining should be to the minimum. Number two, I've shown you the vessels. I'll just go back. I'll show you the vessels laterally. Right. Coming back to the figure. See, I showed you the vessels laterally. Now, what do you do in a paramedian incision? In a paramedian incision, you give an incision here. This is a midline, okay? You go through here, no problem. In a paramedian, what do? You give an incision out here. And then you either split the muscle, rectus splitting, or you retract the muscle laterally. Agreed? Now, when you're retracting this muscle laterally, be very, very careful that you don't retract this muscle beyond this particular area. The moment you retract it beyond this particular area, what's going to happen? You damage the vessels. You damage these vessels, it leads to what? Later on generation of atrophy of the rectus abdominis and ischemia of the flaps. So remember, the applied importance of this part is, number one, do not undermine unnecessarily. Number two, do not retract the rectus abdominis laterally in a paramedian incision to an excessive extent. Don't do that, right? Number three, in retention sutures. What retention sutures? We'll talk about retention sutures. Retention sutures are basically sutures, also known as tension sutures, which are given in certain abdomens where you don't want it to break out. You find a very, very tense abdomen. You have applied suture. You're hesitant in saying that probably it's going to break out at a later point of time. So what do? I apply sutures which will keep these sutures together. That means there are sutures beyond sutures. Now, when you apply these sutures, they are more laterally. When you apply these, I'll show you in one of the further diagram. We talk about the retention sutures. So, retention of any kind, the outer bite should never reach beyond the semillunaris line. Why? Again, the same figure. Again, the same figure. Let's come back to that for just a short while. Yes. Now, you have suture. Suppose you have cut this out, you have suture out here. No problem. Very good. I've done it. I'm happy. Now, I feel that this is going to break down. Why? The whole of the abdomen is tense like a football. Now, I'm not very happy with the suturing. I say, let me apply something else. So, what do? I apply sutures here. I apply suture out here. That means I stitch this and I'm applying the suture here. Now, suppose if I put the suture here, what's going to happen? It's going to constrict my vessels, the inferior and the superior gastric. Will lead to what? Rectus atrophy and number 2, flap necrosis. So remember, if you're going ahead and doing tension suturing, remember this suture should never go beyond the semillunar line. It should be somewhere in this region. It should not be encroaching of the territory of the superior and the inferior gastric artery, because then you'll have problem on your hands, you'll have rectus atrophy, and as it is, these sutures should not be applied. But in case you apply them, it should never be beyond semillunaris line for fear of damaging the major vascular supply and leading to rectal atrophy. A very, very good picture. Just want to show you this. See how these perforators are. Rectus abdominis, this is a cross section, right? The cross section, the rectus perforator. See this? This is the area of the umbilicus. See these perforators. And suppose if I had dissected the whole skin off, what would happen to these perforators? I would have cut all these perforators. That's what exactly happens. All those who are doing this undermine the particular area. See the amount of bleeding? You keep on applying cautery. You keep on applying cautery. Why? It is bleeding. But remember, what is bleeding? The perforators are bleeding. So don't go to that extent. Why do you require that extent? After all, now what has been advised? You should only have a 5 millimeter or less than a centimeter margin to apply sutures. So why do excessive undermining the skin flap? Don't do it. Similarly, this is how the perforator is coming from the deep part of the rectus. See the perforator going up. And this is the midline. You cut, you do a dissection. This is the dissection plane. This is the dissection plane. So what are you doing? You're cutting this perforator, right? So never do that.